The how and the why behind the way EMS treats chest pain. Hello, and welcome to another immersive training experience on extra education and extra learning. I'm your instructor, and today, we're diving into a gripping EMS scenario that will test your skills in managing a patient with chest pain. But before we get started, if you're new here, make sure to hit that subscribe button and ring the notification bell. We've got plenty more exciting scenarios and training sessions coming your way. In this simulation, we'll walk you through the intricate details of a chest pain scenario involving a 58-year-old patient named Mr. John Anderson. We'll cover vital signs and symptoms, medication history, and the pathophysiology behind this critical situation. Stick around until the end, where we'll discuss the best practices for treatment and care. This isn't just a video. It's a learning experience for all aspiring EMS professionals out there. Today, we're not just exploring a medical scenario. We're delving into the life of our patient, Mr. Anderson. This 58-year-old individual is more than just a character. He's a representation of the diverse range of people EMS professionals encounter every day. Let's take a closer look at Mr. Anderson's background. Mr. Anderson lives in a tranquil suburban neighborhood. He's been a dedicated member of the community, a loving family man and a hard-working individual who, until today, lived what seemed like an ordinary life. But today, the ordinary takes a sudden turn. Imagine Mr. Anderson going about his day when he's struck by an unexpected and severe chest pain. This isn't just a simulation. It's an opportunity for us to understand the human side of emergency medicine and real challenges our EMS professionals face. Throughout this scenario, we'll scrutinize every detail, from his signs and symptoms to the events that led him to dial 911. Mr. Anderson is not merely a case study. He's a person in distress, relying on our expertise and swift actions for a positive outcome. Are you ready for the challenge? Let's begin this journey of training and discovery. To begin, I am going to provide you with all the information that we will need for this scenario. This includes vital signs, sample history, and the OPQRST assessment. You may want to pause the video to take notes on each section before continuing. Patient information. Name: Mr. John Anderson. Age: 58 years old. Vital signs: blood pressure 150/90 mmHg, heart rate 110 bpm, respiratory rate 20 bpm, oxygen saturation 95% on room air. Signs and symptoms: complaint of severe, crushing chest pain radiating to the left arm and jaw, shortness of breath, diaphoresis, nausea and vomiting, allergies, no known allergies, medications, takes labetalol for hypertension and Lipitor for high cholesterol. Pertinent medical history: history of hypertension and hyperlipidemia. Last time eating or drinking: he ate a heavy meal about 1 hour ago. Events leading up to the patient calling 911. Mr. Anderson was at home when he suddenly experienced the onset of severe chest pain while watching television. Mr. Anderson's pain started about 30 minutes ago and has not subsided. Pain is not relieved with rest. No known provocation or palliation factors. The quality of pain is described as crushing. Region: radiation. Pain located centrally in the chest, radiating to the left arm and jaw. Severity: describes pain as 9 out of 10 on a scale of 0 to 10. Time: pain has been constant since onset. Severe chest pain, shortness of breath, diaphoresis, and nausea: these are the messages his body is conveying. However, understanding these signals requires a keen eye and an in-depth knowledge of their implications. We'll dissect each of these symptoms, exploring their nuances and what they reveal about Mr. Anderson's condition. The body has its way of expressing distress, and as providers, decoding these signals is our first crucial step. Stay tuned as we unravel the mystery behind these signs, guiding us toward an accurate diagnosis and effective treatment. Now, let's move on to the next phase: the pain assessment. Pain is a complex experience, and understanding its characteristics is essential for our diagnosis. We'll break down the onset. When did this pain begin? Was it sudden, or did it develop gradually? Provocation and palliation play a role. What triggers or alleviates the pain? Does rest provide relief, or is it persistent? Quality is another factor. How would Mr. Anderson describe the pain? Sharp? Dull? Crushing? The region and radiation of the pain are crucial details. Is it localized to the chest, or does it extend to other areas like the left arm and jaw? The severity. On a scale from 0 to 10, how intense is the pain? And of course, the time. How long has Mr. Anderson been experiencing this pain? As we navigate through this assessment, we gain invaluable insights into the nature of Mr. Anderson's discomfort. We will decode the language of pain and move on to understanding the pathophysiology behind these symptoms. Having explored the intricate details of Mr. Anderson's pain assessment, it's time to delve into the underlying pathophysiology. Mr. Anderson has severe, crushing chest pain. The severe chest pain is likely due to ischemia, which is a lack of blood flow to the heart muscle. This can occur when a coronary artery becomes blocked, usually by a blood clot or atherosclerotic plaque rupture. The lack of oxygen-rich blood leads to damage in the heart muscle, causing pain. Radiating pain to the left arm and jaw. Cause. This radiation is a classic symptom of myocardial infarction. The referred pain to the left arm and jaw occurs because the heart and these areas share nerve pathways. The brain interprets the pain signals from the heart as coming from these other locations. Pain triggers the activation of the sympathetic nervous system, leading to the release of stress hormones such as adrenaline and norepinephrine. This physiological response can contribute to increased heart rate, elevated blood pressure, and heightened stress levels. Managing pain helps mitigate the activation of the sympathetic nervous system, promoting a more stable cardiovascular state. As we journey through the physiological responses to ischemia, we'll unravel the chain of events leading to shortness of breath, diaphoresis, and nausea. The sympathetic nervous system's activation, the release of stress hormones, and the impact on various organ systems are all part of this intricate dance within the body. Understanding this pathophysiology is like deciphering the body's code. Let's break down each of the other signs and symptoms that Mr. Anderson is experiencing. Shortness of breath. Cause. The reduced blood flow to the heart impairs its ability to pump effectively. This can lead to pulmonary congestion and fluid accumulation in the lungs, causing shortness of breath. Diaphoresis. Excessive sweating. Cause. The sympathetic nervous system is activated in response to the heart's compromised blood supply. This triggers the fight or flight response, leading to increased sweating as the body attempts to cool itself. Nausea and vomiting. Cause. The activation of the sympathetic nervous system can also affect the gastrointestinal system. Nausea and vomiting are common responses to the stress placed on the body during a myocardial infarction. Hypertension. Cause. Hypertension, high blood pressure, is a pre-existing condition in Mr. Anderson. Hypertension can contribute to the development of atherosclerosis, narrowing of arteries due to plaque buildup, and increase the workload on the heart, making it more susceptible to ischemic events. Hyperlipidemia. Cause. Elevated lipid levels, cholesterol and triglycerides, can contribute to the formation of atherosclerotic plaques in the coronary arteries. These plaques can rupture, leading to the formation of blood clots that can further block blood flow to the heart. Understanding the pathophysiology behind these signs and symptoms is crucial for paramedics to provide appropriate and timely care to patients experiencing a myocardial infarction. Early recognition and intervention can significantly impact patient outcomes. It empowers us to make informed decisions and provide targeted interventions. Stay with us as we move forward to explore the best ways to manage Mr. Anderson in this critical condition. With the understanding of his condition, it's time to discuss the best way to manage a patient experiencing a myocardial infarction. From the administration of aspirin to transportation to the hospital, every step is strategic and time-sensitive. Time is of the essence, and our decisions in these critical moments can significantly impact Mr. Anderson's outcome. Join us as we navigate through the treatment landscape, ensuring that every action is aligned with evidence-based practices and patient-centered care. As we delve into the treatment strategies, it's paramount to exercise caution, particularly when administering oxygen to a patient like Mr. Anderson. While oxygen is a vital component in our arsenal, excessive administration can lead to potential drawbacks. From vasoconstriction affecting coronary blood flow to an increased afterload on the heart, we need to strike a delicate balance. We'll explore the risks associated with hyperoxemia, the suppression of respiratory drive, and the potential for rebound hypoxemia. Each consideration is pivotal in ensuring that our interventions do more good than harm. Let's dig into why too much oxygen can give us adverse results. Administering too much oxygen to a patient with a suspected myocardial infarction can have potential drawbacks. High levels of supplemental oxygen can lead to vasoconstriction, potentially reducing coronary blood flow. In patients with coronary artery disease, this may exacerbate myocardial ischemia. Oxygen-induced vasoconstriction can increase systemic vascular resistance, resulting in increased afterload on the heart. This may be detrimental, especially in patients with compromised cardiac function. Administering excessive oxygen may lead to hyperoxemia, an elevated level of oxygen in the blood. Hyperoxemia has been associated with increased mortality in certain conditions such as COPD and CHF. Rapid changes in oxygen concentration can lead to rebound hypoxemia, where oxygen levels drop below baseline after discontinuation of high-flow oxygen. This phenomenon is particularly relevant in patients with chronic obstructive pulmonary disease, COPD. Continuous monitoring of oxygen saturation is crucial to titrate oxygen therapy appropriately. Adjust the oxygen flow based on the patient's oxygen saturation levels to avoid unnecessary hyperoxemia. This approach helps prevent potential adverse effects associated with excessive oxygen administration. In some cases, high levels of inspired oxygen can worsen ventilation-perfusion matching and impair gas exchange. It's important for medical professionals to be aware of the potential risks of hyperoxemia and to follow established protocols for oxygen administration. Individual patient characteristics, such as the presence of COPD or known coronary artery disease, should guide the decision-making process. Continuous monitoring and frequent reassessment of the patient's condition are key elements in providing safe and effective oxygen therapy. The lungs are a dynamic battlefield where ventilation and perfusion must dance in harmony for optimal gas exchange. In conditions like a myocardial infarction, this delicate balance can be disrupted. As professionals, understanding the physiological consequences of VQ mismatch is crucial. We'll delve into the impact on dead space ventilation, shunting, and how these factors influence oxygenation. Let's take a deep dive into ventilation-perfusion mismatch. Ventilation refers to the movement of air in and out of the lungs, while perfusion involves the blood flow to the pulmonary capillaries. Ventilation-perfusion mismatch occurs when there is an imbalance between the amount of air reaching the alveoli, ventilation, and the blood supply reaching the alveoli, perfusion. In healthy lungs, there is an optimal matching of ventilation and perfusion to ensure efficient gas exchange. Well-ventilated alveoli receive an adequate blood supply, promoting effective oxygenation of the blood. Several factors can contribute to VQ mismatch, including pulmonary embolism. Blood clots in the pulmonary arteries can obstruct blood flow, leading to areas of the lung with reduced perfusion despite normal ventilation. Pneumonia. Inflammatory processes in the lungs can lead to areas with decreased ventilation but maintained perfusion. Chronic obstructive pulmonary disease, COPD. Conditions like emphysema or chronic bronchitis can result in areas of the lung with impaired ventilation but maintained perfusion. Atelectasis. Collapse of lung tissue can lead to areas with reduced ventilation. Dead space ventilation. Ventilation without perfusion leads to dead space, where air is not participating in gas exchange. Increased dead space. As a response to stress and pain, shallow breathing may lead to areas of increased dead space ventilation. Shunt. Perfusion without ventilation results in a shunt, where blood passing through the lungs does not undergo oxygenation. Oxygen titration. Careful titration of oxygen to avoid hyperoxemia while ensuring adequate oxygen saturation. Continuous monitoring. Monitoring for signs of respiratory distress and adjusting interventions accordingly. Understanding VQ mismatch is essential for medical professionals in managing patients with conditions like myocardial infarction, where optimizing oxygenation is a critical aspect of care. Tailoring interventions based on the underlying pathology and individual patient characteristics is key to providing effective and safe treatment. Now that you have had a chance to review Mr. Anderson's case, let's break down the EMS treatment for Mr. Anderson. Primary assessment. Begin with a primary assessment to ensure the patient's airway, breathing, and circulation are stable. Administer supplemental oxygen if needed. In Mr. Anderson's case, his SpO2 is at 95%, so oxygen may not be needed at this time. However, the placement of a nasal cannula may help the patient feel as though you are helping to fix the respiratory distress. Vital signs monitoring. Continuously monitor vital signs, including blood pressure, heart rate, respiratory rate, and oxygen saturation. 12-lead ECG. Perform a 12-lead electrocardiogram, ECG, to assess for ST segment elevation or other changes indicative of a myocardial infarction. Establish intravenous IV access. Establish IV access to administer medications and fluids. Aspirin administration. Administer aspirin, if not contraindicated, as it helps prevent further clot formation. The typical dose is 324 mg, chewed, unless the patient is allergic or has a contraindication. Nitroglycerin administration. Administer nitroglycerin if systolic blood pressure is greater than 90 mm of mercury and there is no contraindication, e.g., recent use of erectile dysfunction medications, hypotension. Nitroglycerin helps dilate coronary arteries, improving blood flow to the heart. Pain management. Administer analgesia for pain relief, such as morphine or fentanyl, if needed and not contraindicated. Pain management plays a role in maintaining cardiovascular stability. Uncontrolled pain can lead to increased sympathetic activity, potentially causing arrhythmias or elevations in blood pressure. By effectively managing pain, the goal is to promote cardiovascular stability and reduce the risk of further complications. Prepare for transport. Prepare the patient for rapid transport to the nearest appropriate medical facility with cardiac catheterization capabilities. Continuous monitoring and reassessment. Continuously monitor the patient's cardiac rhythm, vital signs, and response to interventions. Reassess the patient's pain level and adjust analgesia as needed. Communication. Communicate with the receiving hospital to provide a detailed patient report and ETA, facilitating seamless transfer of care. It's important for EMS to follow established protocols, collaborate effectively, and prioritize timely interventions to optimize outcomes for patients experiencing a myocardial infarction. Additionally, ongoing education and training in evidence-based practices will enhance their ability to provide high-quality care in emergency situations. Thank you all for joining us on this immersive journey into the world of emergency medicine and EMS training. I hope you found this scenario not only informative but also thought-provoking as we explored the intricate details of Mr. John Anderson's situation. Remember, these simulations are more than just exercises. They're windows into the real challenges that EMS professionals face daily. Your commitment to learning and staying informed is a testament to your dedication to providing top-notch care in emergency situations. If you found value in this video, don't forget to hit that like button and share it with your fellow EMS enthusiasts. And for those who haven't already, consider subscribing to Extra Education and Extra Learning for more engaging scenarios, in-depth training sessions, and valuable insights into the world of emergency medical services. As we close this chapter, let's keep the conversation going. Share your thoughts, questions, or your own experiences in the comments below. Your input enriches our community of learners and professionals. From all of us here at Extra Education and Extra Learning, thank you for being an essential part of this learning journey. Stay passionate, stay informed, and most importantly, stay safe out there. Until next time, this is your instructor signing off.